Up next, we have Milica Medved and Dr. Armato with the University of Chicago, both of which who will be presenting together what's new in imaging for appendix cancer. Milica Medved is a research associate professor at the Department of Radiology and has over 20 years of experience in the development of quantitative MRI methods with the main focus in cancer detection and diagnosis, as well as treatment and monitoring. Dr. Armato is an associate professor of radiology and on the Committee on Medical Physics at the University of Chicago and focuses on the development and evaluation of computerized techniques for the quantitative analysis of medical images and the assessment of tumor response to therapy. So thanks so much, everyone.
Great, thank you very much, Lauren. It's a pleasure to be here. It's my honor to present with my colleague, Dr. Medved, on what's new in imaging for appendix cancer. We'll take a little different view with this presentation. We've done a lot with our groups over the years in evaluating by imaging peritoneal and pleural mesothelioma, specifically with CT. And so our group is now taking this experience and leveraging it into the potential for metastases to look very similar to peritoneal mesothelioma from appendix cancer. And so with that in mind, I want to talk a little bit about the work I've done in CT and the power of CT to image first lesions in the lungs and chest, and then leverage that into MRI of the abdomen where it's more relevant to appendix cancer metastases. So CT and MRI are both powerful tools for visualizing patient anatomy and allowing physicians to diagnose disease in those anatomic regions. Especially important is the potential for contrast enhancement of structures, and I'll show you some images of that in just a second. So CT scans tend to be the first line of defense with regard to diagnosing disease. It's a more common type of modality, a little cheaper than MRI, and it provides good resolution of smaller structures within the patient. So here's an example of a CT image of the chest, and what we're seeing here are the lungs, and we're seeing some collection of fluid within the pleural space between the lungs and the chest wall. Now, as I mentioned, injecting intravenous contrast agent into the veins of the patient allows for that agent to course throughout the vasculature of the patient and highlight structures within the patient that allow us to differentiate adjacent structures that appear anatomically. So on the left, we see a CT scan of the chest, and there's no contrast in this image. And a lot of the structures are kind of water-based. They appear very similar when they interact with the X-rays that are involved in the CT scan acquisition. On the right, the patient has been injected with IV contrast, an iodine-based contrast that is coursing through the patient's vasculature. And here we see very clearly a distinction between the visual appearance of the patient's aorta and other soft tissues within the patient, the muscles. And here again is that fluid in between the lining of the lungs. That can be even more greatly enhanced for visualization if we take multiple time points and we take images that allow for us to visualize the contrast coursing through the patient's veins, as well as potentially the tumor with different signals between tumor and adjacent structures. So here's an example of that, a dynamic contrast enhanced CT scan. The patient has been injected intravenously with the iodine contrast agent, and we see one section of anatomy over time within a single scan that is showing the blood flow and carrying with it that contrast agent to various structures within the patient here. Viewed a different way in the surface rendering, we see much more clearly, much more dramatically the enhanced visualization that can occur when we use contrast agents in our imaging modalities. So with that, I'll turn it over to a discussion of MRI. I could just advance one if you want me to just slides.
I can't. Okay, so hello everyone. I will be talking about how the MRI can help with the visualization and tracking of peritoneal metastases. And currently, MRI is not used much because the resolution is lower than that of CT and it is more expensive. However, MRI can visualize tissue in many different ways. This is an inherent advantage over CT, and if we could harness this potential, we could improve clinical care. So can we improve the performance of MRI enough to transition disease monitoring from CT and sometimes surgery to non-invasive MRI? Our group here at University of Chicago Medicine is testing a novel MRI protocol design. We were able to increase the resolution, so we have a higher resolution to detect smaller lesions. We're using a higher dose of contrast agent to enhance visualization of abnormalities against a background of normal structures. And we have extended to longer follow-up of signal after contrast agent injection with up to 20 minutes to allow greater visual differentiation between adjacent structures. This is what it looks like in practice. I'm here showing an MRI image. It's a cross-section of the abdomen of a patient with peritoneal mesothelioma, which is, as Sam explained, the model for peritoneal metastasis of different etiologies. And in the dashed square, that section is blown up in these two bigger regions. Thanks, Sam. And the yellow lines show the lining, the peritoneal lining that has metastasis on it that is not showing really well after 9 minutes after injection, but is showing much better at 19 minutes. So this is something we pioneered. Normally, 9 to 10 minutes is what is recommended, but we are testing longer delays. This new protocol that we're testing improves our ability to visualize small and flat lesions. Initial measurements show sensitivities of 89 to 100%. The question is, are there many false positive findings? This is something we're now testing to evaluate the complete diagnostic accuracy of the protocol. Another set of unique data that we're achieving is following the lesions over time. As we saw, some will continue to enhance over time. And at the bottom on the graph, we're showing the signal within the lesion, and some of the lesions, like the gray, red, and blue, continue to enhance over time, while some do not, like the green and yellow. So the question is this information useful clinically? And this is something we're currently working on. Finally, I would like to acknowledge all the members of our team.